questions that you have in the chat, or make a note of them yourself, and then you could ask at the end. I think it might be quite nice to do a bit of a free-for-all at the end, if that's okay. Actually, having said that, are all the presenters going to be here at the end? Just to double check.
The only thing is that Grace is only going to come at 3 o'clock, so we might have some time to do some questions before the very end.
Okay, so perhaps we could have one question after each presentation, and then if there are extra ones, we could have a bit of a free-for-all at the end. That sounds good. So without delay then, we'll turn to Dr. Rebecca O'Brien from the University of Nottingham. Rebecca works with Alison and lots of other, Alison Pilnick, I should say. Sorry, Alison, that was a bit informal. And lots of other great people from the University of Nottingham, Alison now at Manchester. But they've got a fantastic project called the Voice Study. And Rebecca's going to be talking about developing evidence-based communication skills training for hospital staff who work with people living with dementia. So I'll pass over to Rebecca to explain the kind of outline of the presentation. Do you want to start sharing your slides,
Thanks,
Rebecca?
Joe. Include sound, don't forget. And then, there we go. Is that okay?
That looks good.
Up on the screen?
Yeah,
brilliant.
that looks perfect.
Well, thank you for welcoming us here today. Alison's in the audience, as it were, today, so I'll rope her in at the end if you ask me any difficult questions. So thank you. Yeah, thanks for having us here. So just to say, we've been funded by the National Institute for Health Research for most of our studies, and the videos that we show today have been consented for showing in this kind of context. Any original names are silenced in the recordings, and the names are changed in the transcripts as well. So we're delighted now to be working on our third study under the Voice group of studies. Voice stands for Videoing to Improve Communication Education, and videos, as you'll see, are central to our methods and our training. And what underpins all three studies is the goal of improving communication for people with dementia in the particular context so far of healthcare communication in acute hospital settings. So the original Voice study, so that's the logo in the top right, examined what worked best in healthcare professionals' communication to support those people with dementia who had communication difficulties. And from that came our second study, Voice 2, which explored what healthcare professional practices best avoided or managed distressed behaviour, which was something that our trainees in Voice 1 identified as challenging for them. And we're now working on Voice HF, which stands for hip fracture, which is going to look at practices for supporting people living with dementia after hip fracture surgery in hospital to support early mobilisation. So just going back to the start, so that was in 2015. I can hear somebody else speaking. Am I okay? Okay.
You're fine, but maybe we could just remind everyone to put your microphones on mute, if that's okay.
Fab.
Apart from you, Rebecca, of course.
Thank you. So the context for the first Voice study, and for really all of those that have followed, is our concern for people who become acutely, severely ill and require hospital care, but also happen to have dementia. So we know that they occupy about 25% of UK hospital beds. And despite it being more than 20 years since Tom Kitwood wrote his seminal text on what person-centred dementia care might look like, we still have patients, carers and staff reporting that communication problems lead to poorer care, high stress, and for staff, low job satisfaction. And even so, there seems to be a lack of evidence-based training for hospital staff in how to communicate better with hospital patients with dementia. And we know evidence from a review of communication skills in healthcare by Ruth Parry suggests that the best communication skills training is based on sound empirical underpinnings rather than just relying on expert opinion, because it turns out that we don't always know what we do in communication or what works best in our own communication. So we've argued that we need to know more about what works best in this context, and it's a communication puzzle that we've been trying to solve or work on. So both the Voice 1 and the Voice 2 study used a similar research design, which was this kind of three-phased study design. So we start off by asking, what should we train? So we establish what we should train, identifying what works in particular interactional contexts through a new empirical study of naturally occurring interactions. And then in phase 2, we decide how we should train using groups of expert stakeholders to develop training interventions that promote the identified practices from phase 1 of the study. And then in phase 3, we've done some sort of evaluation. Can the training be delivered? How do we implement it? What works best? Does it look likely to have an impact on staff knowledge and communication behaviours, or even on patient outcomes? Just to say that Voice HF, we've just got funding for the first phase of that study. So how do we identify what we should train? So we use a sociolinguistic research method called conversation analysis, which involves collecting naturally occurring video and audio recordings of interactions in the real context and closely analyse them. So just to unpack that, this is really a background slide for anyone who wants to look into conversation analysis afterwards. So and just to show that we didn't invent it. So there's lots of conversation analysis that has been used in healthcare interactions. So in the context here of stroke, psychosis, primary care and neurology. And those papers at the bottom from Rebecca Barnes are really helpful papers summarising some of the healthcare literature that uses conversation analysis if you're interested. So what is it? So it's a sociolinguistic research method that examines what people actually say and do rather than what they think they do. And it examines the detailed sequential processes of the interaction. So what leads to what leads to what, and it always uses recordings of real interactions. So this photograph is from one of our recordings, and so you can see from that picture that we don't always get people's faces perfectly. There's plenty of wobbly camera work and lots of background noise. And that's the real life, isn't it, for both people with dementia and staff on hospital wards. They're dealing with noise levels, for example, all the time. And using this method means that we aren't inventing what we think people ought to do in their communication, but we're looking for what good practitioners actually do that we can see to work in the interaction. And the process of analysis involves, so we start looking through the data, the video recordings, for things that stand out. So that's like using binoculars to spot a rare or exciting butterfly. And then we make a collection of those interesting phenomena, those butterflies, if you like, clipping and marking them. And when we have that collection, we then examine the collection in forensic detail. So using a microscope, if you like, on the interaction, seeing things you wouldn't have seen otherwise. So they'd have been there all along, but we wouldn't have been aware of them without that forensic analysis or detailed analysis. So this is just an example of a real transcript from a data session from my colleague Isabel Wendy at Harrison, who's worked with us on Voice 2. And that was from an internal data session. So when we've watched the videos, we transcribe them, to a high level of detail. We try and record things like the pitch and the volume and the silences and the gestures. And then we review the recordings and transcripts multiple times, and we watch them together with other people in what we call data sessions, and we share our noticings with each other, which supports the credibility of our analysis, because multiple people can watch the same thing and see how we compare in terms of what we think is important. So what did we get in our data? So in Voice 1, we got 41 films, about 6 hours in total. They range from 2 to 30 minutes, and you can see we got data from about 27 staff and 26 patients across 2 hospital wards. And you can see that we got a mixture of healthcare professionals, so nurses, therapists and doctors. And in Voice 2, we had slightly more, so we've got 53 recordings, and we collected data in 2 different teaching hospitals, so we've got a bit more data, 9 hours and 45 minutes, 22 patients with dementia, so people were recorded more than once, and 52 staff recorded. And the yellow and grey bits of that pie chart are nurses and healthcare assistants, so you can see that the majority of the data this time was from people that might be described as part of the nursing team, so fewer doctors and allied health professionals this time. So this was obviously when we were looking at the patients that had shown distress. So just to say that the patients, only one of the patients out of the 2 studies was assessed as having full capacity to give consent to participate in the study. So we have consultee agreement for the vast majority of the patients who participated in the study. So here are some examples of photographs taken from the Voice 2 data of patients that were showing distressed behaviours. So in the top left, we have a lady who was shouting out and refusing. The gentleman in the top right is banging on the door. You can perhaps see his fist. The lady in the bottom left was swearing at staff as they tried to change her, and the bottom right, the lady shouting repetitively help. So those are the kind of distress behaviours that we managed to capture in our recording. So what kind of things does conversation analysis identify as being challenges in interaction? So this is where it's really interesting, because we don't start off with an agenda. We don't know what's going to come out of the data. So from our analysis in Voice 1, we identified the interactional trouble or challenges occurred in 3 places that we analysed. So the first challenge was in what we call the business phase of the interaction. So how do we request patients to do important healthcare tasks when they show reluctance or they refuse? And in the closing phase of the interaction, we found there was a challenge about how do we close the encounter efficiently and supportively when the patient doesn't align with that closing? How do we do that without being rude? And then finally, through every phase of the interaction, how do we remain connected to patients when their talk is really hard to interpret? So we've written papers on each of those areas of trouble, and the training for Voice 1 includes modules on each of those. And then in Voice 2, so these are the areas of interaction that we identified as being important in avoiding and managing distress. So these 3 areas form the 3 modules for our learning. So the first one is about dealing with different realities. So this asks, how should I respond when a person I'm caring for thinks they're in a different time, place or situation? And the second module is around following the rules of conversation. So when patients point out that I've not responded appropriately, so for example, I've not answered their question, how should I respond? And thirdly, accounting for care and justifying the care we deliver. So how should I communicate about tasks that I know might cause discomfort, pain or distress, or they actually are causing discomfort, pain or distress? And how do we communicate in all of those situations to reduce or avoid distress? So those are the kind of things that we identify in the phase 1 of the study as things that we could train, and that are those empirical underpinnings we were talking about earlier. And in the phase 2, I just wanted to give you a flavour of how we developed the training interventions. So this was a diagram for Voice 1. So we had an expert panel to develop the training intervention, and we discussed as a panel. We met 4 times, I think, over 4 whole days. We looked at the evidence from a systematic review, from the conversation analysis. We had some individual interviews with experts, and then we did exercises to come up with a consensus around what the training should look like, how long it should be, who should deliver it, what kind of methods of training we should use, and so on. And what we came up with for Voice 1 was that we would come up with an advanced communication skills package that was for registered professionals like allied health professionals, nurses and doctors. And that's because they were the people we'd recorded in the first study. That we would deliver the training in interdisciplinary groups, and that we would do 2 whole days of training with but spaced apart with a month in between. And we'll talk about why in a minute. That it'd be delivered by 2 facilitators in small groups, and that it would be experiential, didactic and reflective learning approaches used. And we particularly worked on developing simulation, which I'm just going to talk about in a minute. And that's a photograph from one of our simulations, I think. So these are the sort of teaching methods that we decided to utilise. So video analysis, what we mean by that is a technique that's sometimes used in conversation analysis, where we stop and start the video, where we play it. So we play a micro clip of the patient maybe saying something, so say something difficult to interpret. And then we ask trainees in the room what they might say in response. What do they think they would say if they were with that patient? And then we compare what they've said, they might have said, to what happened in the actual recording when we play it, and see how it plays out in the real recording. So that's the video analysis or stop-start technique. We also developed some e-learning resources and a website. We piloted the e-learning resource between days 1 and day 2 to support the learning. And we're now developing a website for Voice 2, which I'll talk about later. We also have a reflective diary exercise, which trainees really report positively on, which is we ask trainees to come back to the day 2 training with reflections on an interaction that went well and one that didn't go so well. And we use small group discussion to reflect on that. And then we've used simulated encounters in Voice 1. So professional simulators, if you're not aware, they play the part of patients in training scenarios to allow skills practice for healthcare professionals, and they're very skilled actors in improvising and in giving feedback. So simulation in healthcare trainings is experienced by healthcare professionals as being helpful for giving real-time practice of skills, real-time sort of immediate feedback, and to give an opportunity to observe peers trying things out in a way that we don't normally get in everyday practice. But there are authenticity challenges. So some social linguists are concerned that the interactions in simulation are not really authentic. So what we did was to try and improve that authenticity by developing a simulation method based on CA. So we've called that CABS, and that's the paper that Alison Pillick's the lead author on, who's here today. And so I wanted to show you a quick clip of Stan. So this is one of our simulators with a trainee. So Stan was trained based on real interaction to not sit down and to politely refuse to eat and drink. And the healthcare professional has been asked to try to get Stan to drink half a glass of water and try a biscuit. This is about 40 seconds of them. Apologies, the volume is quite quiet on the recording and there's no subtitles. So just whack up your volume if you can't hear it.
Just let me under the. I need to get this one under the that. Stan, yes. That looks nice. That looks magic. No, he wouldn't want to do that. Thank you.
You need to get better though, and to do that you've got to start drinking a little bit more.
I need to get better. Yes.
Yeah.
But
so you have a drink.
If you don't do the work, you don't get the money, and people think you get the money without doing the work, and then they get annoyed, and then they get surprised that it's not working because it's not on the quote. It's not itemised on the quote.
Stan,
yes, my darling.
You have a drink of water.
Just a drink of water.
Yeah.
So apologies for the quietness. So for Voice 2, we went through a similar process of stakeholder workshops. And this time we weren't using simulation, partly because we didn't have the funding for it, but also because we'd found it wasn't very easy to sustain for healthcare professionals delivering training in their own hospitals. So we developed 2 half days of training with the reflective 2 to 4 weeks in between. We included skills practice, we included video role play, the stop-start technique, and we've included some educational films that we've developed as well to support trainers in delivering it, and the website, which I'll show you at the end. So just briefly to give you an experience of it, one of the modules is around dealing with different realities, as I said. So how do we respond when a person we're caring for thinks they're in a different reality or situation? So we ask trainees to come up with examples from their own experience and write them down, what patients have said to them when they're in a different reality, and then we problem solve those later on. So we're now going to watch Alison, in fact, apologies to Alison. This is one of the educational videos that we use talking about how healthcare professionals respond in different ways to a patient being in a different reality.
What we found in our data is that 3 main types of responses occur, and they occur along what we call the response continuum. So at the one end, you've got responses that challenge or deny the patient's reality. So somebody might believe they're at home in their own house, and you might keep telling them that actually no, where they are is in hospital. What you've got at the other end are responses that go along with the patient's reality and develop or elaborate that in some way. But what we also found was that those 2 types of responses at either end are in the minority in our data, and where most of the responses happen is in the middle of that continuum. What we see more often in those types of responses that are in the middle of the continuum is that healthcare professionals do something to try and create some shared aspect of the reality, so to create something that they can both understand and agree on.
So we unpack each part of the continuum by analysing it together with the trainees, showing lots of short examples. I'm going to show you one of those today from the middle of the continuum. So this is a clip of the patient who we're calling Julie. She's been walking around the ward for some time, continuously repeating that she wants to go home, saying, I want to go home, I want to go home. And she's having one-to-one support from this healthcare assistant, mainly because she's at risk of falling. So have a watch and see what it is that Julie does to explore, what the healthcare assistant does to explore Julie's reality.
I want to go home.
I know you do. I understand
I
that.
want to go
Who's
home.
at home?
I want to go home.
Can I ask you, who lives at home?
The dad and the mum.
Do they?
So the healthcare assistant here asks a really simple question about who lives at home, which explores Julie's own topic of home further. And Julie's able to respond with a related answer about her parents, which breaks her out from her repetitive quest about going home and gives the potential for a new and important area of shared understanding and conversation between the two of them, which the healthcare assistant can then use to gain new information about why Julie might want to go home and so on, and to explore together in conversation. So then we would give trainees an opportunity to practice with each other what sorts of things they could say in response to the examples that they came up with earlier around different realities following the training, how they might change it. And this work's already published, so that's the paper in Social Science and Medicine. Alison's the lead author on, and she's also written a great paper, a lovely accessible article in The Conversation, which is the one on the right. So just to think, the module around accounting for care. So here's another example, and I'll just show you the clip. So this is a lovely example of somebody accounting for their care. So that's explaining the reason why they're doing something to the patient in this example. So have a watch of this one.
Just going to take this out. I'm going to take the pillow out.
Okay.
All right? And then we'll get you up the bed so you can have some lunch. All right?
Okay.
So this gentleman, who we're calling Ken, frequently called out in distress during this kind of personal care, but here he seems very contented. The healthcare assistant describes to him what she's going to do. I'm going to take this out and then we'll get you up the bed. And then she says, so you can have some lunch. So she gives this account or justification to justify the disruption to Ken, and then checks it's okay with him, with all right. So those are the kind of things that we unpack in the data. So just in terms of the evaluation, I'm running out of time. So people said in voice 2 that 91% intended to use it in practice. The knowledge scores increased slightly. They were high before the training anyway. They liked the 2 half-day formats. They described a range of learning, which included evidence that they were using all 3 of the trainables that we'd had in all the modules in the training. Here's an example about the reality. Before, all the time, I always bring them to their reality, because I think in nursing school, that's what they taught us. I didn't know before that you could join them and then explore a bit of what they're experiencing, because they could be in a different time of their life. We also find that people talked about increased confidence communicating with distressed patients. So we had a ward manager identifying that staff, her training nurse associates, were much more confident after they'd attended the training, and people described that for themselves. And there was some evidence that there was impact beyond those trained. So they were sharing what they'd learned with other people on the ward and beyond the ward as well. So just to say, this is the website that we're still putting together, but it should be available, I'm hoping, by the end of this month. So it's called voicestudy.co.uk. At the moment, it says under construction, I think, if you go to that website, but hopefully it will be live very shortly, and that will have modules freely accessible if you register to receive them. So thank you for listening. Just to say that the paper by Professor Harwood at the bottom of the there is another really accessible paper that summarises the findings from both voice studies, and then Alison's paper again. So thank you very much, and I'll stop. Thank you. So any questions, welcome now, if we've got a little bit of time. Just bring up the chat in case anyone wants to.
Emily. Oh, sorry, we've got 2. We could probably fit them in. So Emily, do you want to go first, and then Jennifer after that?
Yeah, thank you, Becca. That was a really interesting presentation. I was wondering about your recruitment and how you found that, and if there was some resistance to people being filmed.
And are you thinking about patients or healthcare professionals, or
well, healthcare professionals predominantly, but both, I suppose.
Yeah. So I mean, we're so grateful to people for being willing to be recorded. It's brave, isn't it? I don't know. I'm a clinician myself, and I don't know how enthusiastic I would be about being recorded. But I think we did a good job of selling the fact that we were looking for good practice, and I think that's one of the things that, we're not looking to trip people up, and this research method isn't really interested in that particularly. I think we had good relationships on the ward, and I personally felt it was helpful that those of us that were recording were also recruiting. So we didn't use, for example, Clinical Research Network staff to recruit people. So they were meeting us, and when we said we're looking for good practice, we're not looking to trip you up, hopefully I assume they did trust us, because lots of people did agree to be filmed. I think we were fortunate that one of the wards, they have had some experience of being filmed for documentary type things from research projects in the past, and so most staff had already made decisions about whether they were happy to be recorded or not. They just said, oh no, I don't do that. And it was often about people's their kind of opinions about how they looked, really. It was often about that rather than the practice. But also in terms of sharing, obviously the people you've seen today, those videos, so people could be part of the research project but not consent to them being shared in settings like this. So obviously people that were less confident or felt more uncomfortable, after we'd recorded them, we would then ask them whether they were willing for us to use those recordings in conference presentations, in the training, online, and so on. And so people, if someone agreed to be in the study but then were uncomfortable with how they'd appeared, they just said, I don't want anyone else to see it, but I don't mind the research team seeing it, but I don't want it shared. So I think that process has been really helpful.
Yeah, great, thank you.
And Jennifer, do you want to ask a question? And then we might have to move on to the next presentation. I can see, Patricia, you've got your hand up. If you wouldn't mind, you could make a note of the question and pop it into the chat, or just make a note of it and ask at the end, but there'll be a little bit more time for questions on the presentation. Thanks.
Super. Mine is really practical. I'm wondering, how did you actually do the recordings? Did people have like body cameras, or was it an actual camera or their phone? How did you do that?
So we had proper cameras and also digital audio recorder as well, digital recorder, so double. And we made no attempt to hide, because I actually felt more comfortable actually with being very overt about it, particularly because the patients weren't usually able to give consent, but we would show them the camera, and if they reacted badly to the camera, then we didn't pursue it any further anyway. So I didn't want people to forget that we were there in the sense of it being done covertly. So it was done quite overtly, really. Yeah.
Great, thank you.
Brilliant. Thank you so much, Rebecca. That was
Pleasure.
so interesting, and I have a million questions as well. But for the sake of time, we'll move on to the next presentation, and hope that we have a little bit of time at the end for questions for everyone. So the next presentation is from the Time for Dementia team, which from Yvonne Feeney and Wendy Stevens. And Time for Dementia, I won't say too much about it because they'll explain it, but it's a program where healthcare students are matched with families living with dementia in order for the students to, over a period of time, to have a better understanding and deeper understanding of the lived experience of dementia and how it progresses, and how that kind of impacts their understanding of the condition. So I believe that Yvonne, you're talking first on this, I think, and you're sharing the presentation. Is that right?
I'll just do a brief kind of introduction.
Oh, it's Wendy first, sorry.
That's all right. Yeah, that's fine.
Okay. Okay. Wendy, would you like to share your screen?
Yeah. There with.
Brilliant. Yeah, we can see that. That's great.
Can you just see the big one? You're not seeing everything else that's underneath.
Just the big one, yeah. Yeah.
Okay.
It's always good to check though.
Hi everybody, my name is Wendy Stevens and I work for the Alzheimer Society, and this is a joint presentation between myself and, as Joe said, with Yvonne Feeney, who I'm sure will introduce herself. So mine is very brief. I'm just going to tell you a little bit about what the Time for Dementia programme is. And then Yvonne is going to present the research from the research findings. So first of all, just kind of what is Time for Dementia, or what's it about? It's an award-winning educational programme. It has won lots of awards over its time. It's been going now for 11 years. We had our 10th anniversary, I was going to say wedding anniversary, our 10th anniversary last year. It was launched initially at Brighton Sussex Medical School. And the overall aim of the programme, as Joe's already mentioned, actually, is to prepare the future healthcare workforce in dementia. So we're aiming to improve their knowledge, their attitudes and empathy that we believe they need to be able to deliver compassionate care to people with dementia, and also their families, their carers. So what happens is that students in pairs are allocated to a family, and they visit that same family over a period of 2 years. So they do 3 visits in year 1, 3 in year 2, and the visits are in the family's own home. So at the moment we don't go into residential or nursing homes. The visits take place in their own home. Just for kind of context, over the period that the programme's been running, we've, well, I think it's more like 3,000 families, nearly 3,000 families now have taken part in the programme. Obviously, some of those have come and had to withdraw and leave us, but over the period of 10 years, we've had a massive amount of families who've been involved with us and have helped us. And the figure there is about 9,500 students that we've trained, but I think that's a year behind as well. So that's kind of context, that it's how the kind of size of the programme. We're continually trying to improve the way we do things. We've just recently, over the last year, got a new family engagement team to help us run the programme so that it is meeting more the needs of not just the students but also the families that take part. Excuse me 1 minute, my dog is jumping about, hang on. She gets very needy about this time, so sorry. So I work in partnership with UE, University of West of England, probably all know, but there are 10 other universities that are taking part now in the programme. Our most recent university to join us was the University of Belfast, so we're really pleased. They've got about 400 students that they're about to train this September. We've got a range of healthcare professionals that we train, doctors, nurses, dietitians, the list are all there. But at UE we train paramedics, occupational therapists, physiotherapists and mental health nurses, and UE are now in their 3rd year of running the programme, which is really great. So how do the families get involved, and what happens? So a family to be involved, as I said, they have to be living at home, and it's really important that when the students go out to see their family that there's a carer or family member with them, so the person with dementia is not seen on their own. And that's for safeguarding reasons, but mostly because we want the students to understand how dementia impacts the family and the care of those around them, not just the person who has a diagnosis. So once the referral comes through to us, we, myself or one of my colleagues, there's about 12 of us in the team, we go out and visit the family at home. We spend about an hour and a half with them to explain about the programme so they fully understand what's involved. We talk about consent and also data protection. So the families get a lot of support before they join the programme. During the programme, we keep in contact. We phone the family after the first visit to make sure things have all gone to plan. And then throughout the 2 years were mostly in contact with families for some reasons or other. So
Mom, did you go to your place? Oh, nice.
That's not me. So this is Natasha, one of my colleagues, talking to one of our families. This is a nice happy photo. So what happens at the visit? So as I said, the families are paired up with 2 students, and they visit 6 times over the period of 2 years. We get in the university mostly look after the students, and the Time for Dementia team at the Alzheimer Society look after the family. So there's a kind of partnership working there. We're looking after the families, and the university obviously after the students, looking after the students. So the visits are meant to be very informal, a little bit like meeting a new friend. So the first visit tends to be about just getting to know the family, their interests, hobbies, families, how the diagnosis came to be, what kind of led people to get a diagnosis, what attitudes or how people have treated them since. So that's mostly the kind of first visit. The visit's about an hour and a half. Other kind of topics are like these ones on here that hopefully have just popped up. It may be about thinking about the future, a day in the life maybe now and years before, communication, nutrition often comes up, nutrition and hydration. So there are no strict rules, which is, I think, one of the lovely things about the programme. The students aren't tested at the end of it, so they're not given a list of things that they have to learn. It's very much driven by how the families, how they've experienced living with dementia. Everybody's different. But the students do a reflection at the end of their visit on that day and talk through that reflection with their practice assessor. So it's I think it's a nice way to learn, because then the students aren't under pressure to learn specific things. It's whatever they learn from the family is going to be beneficial. So that's one of our long-standing families, and as I said, it has to be at home, but it's, they don't have to sit there around a table or opposite each other. They can kind of take part in things that are going on at home. I had a family, I phoned a family yesterday who said their students had offered they were occupational therapy students, and during the visit they'd offered to paint some plant pots with the family. So because they'd found out that the person with dementia was very creative and they enjoyed gardening. So that's a nice way to just develop communication and be able to talk about things and find out what life is like. So it's all very informal. What's next? Doesn't want to move. Oh, so this is just my little ask while you're all here. So we need families to take part. It can't run without families, recruiting families. So if you know of anybody who might be interested in taking part in the programme, it's very easy. Just please talk to people about the programme. I've got a leaflet which I can share later, and it's very easy to refer people through to us, and we'll go out and visit them at home and give them all the details. And that is me. So Yvonne is going to take over next and talk about the research side. So I hope that's all been okay.
Thank you so much, Wendy. I'm going to
thank you.
Steal the screen.
So I'll stop sharing. Here we are.
Thank you. And there we go. Can everybody see that?
Yep.
Yeah, excellent. So my name is Yvonne Feeney. I'm based at Brighton Sussex Medical School, as Wendy mentioned there. I have a couple of different hats. So I work on the programme itself. I support universities to implement it. I also work with our research team. I'm a PhD student. I've just submitted my PhD, and that looked at empathy towards people with dementia. And I'm a nurse by background, so all of that kind of culminates into kind of my role on Time for Dementia. So I'm going to talk to you about some of the research that we've done on the programme. And as Wendy said, the programme has been running now good many years, 11 years. So we've done lots of different research. So I'm going to take you on a whistle-top tour of some of the research we've done. So, so basically, the three kind of areas I thought I'd kind of think about today is just to give you a quick overview of some of the quantitative research we've done. I've kept out the statistics, but I've given the link to the paper if anybody's interested. So to just talk about kind of differences in knowledge, attitudes and empathy in students who've taken part in the programme. And then I'll talk about the qualitative experiences of both students and families who took part in the programme as well. And then I'll finish with the words of some of our students. Of one of our students, actually. So the first study was our quantitative study, which looked at student knowledge, attitudes and empathy towards people with dementia. And what we did, we were really interested to understand kind of, I guess, any differences in learning in students who took part in the programme versus those who didn't. So we used a series of questionnaires that looked at knowledge, attitudes and empathy. So there were 7 different questionnaires in this pack. And we asked a group of medical, nursing, allied healthcare professional students and paramedic students to take part in this research across 6 different universities. And this group of students were made up of, there was 24 different groups of students who were taking part in Time for Dementia, and there were 6 comparison groups. So that was kind of the overall sample. In this, we had about 3,000 students who signed up to I suppose, who completed baseline measures for us. About 80% of those were, or just under, were female students. The average age was about 21 when they started doing this, so around about the time they'd be starting visits. And just over half of the students didn't have any experience of dementia when they first did those questionnaires and when they first started out on those visits. So basically, we compared the learning outcomes from those students who took part in Time for Dementia versus those who didn't. You can see the numbers there of students, of the paired data we had available. We lost a lot of students during COVID, unfortunately. So we had about almost half the sample actually we lost. But anyway, when we compared the outcomes between the two groups, we found that students who took part in Time for Dementia gained statistically higher knowledge of dementia and more positive attitudes towards dementia than students who didn't take part in the programme. So that was some really positive outcomes for us. We didn't find differences between the two groups in empathy, though, which was quite interesting and made up the bulk of my PhD afterwards. But that's a whole different presentation. There is a QR code there if anybody's interested to really read the detail of that study, because as I said, I won't go into the nitty-gritty of it because I'll go over the other two. So the next study I'm going to talk about is around understanding student experiences in Time for Dementia. So I'm a qualitative researcher at heart, so this is an area that I really enjoy talking about, I think. So basically we did a series of individual interviews with students and we did 5 focus groups. We invited again medical, nursing and paramedic students to take part in this piece of research, and we used thematic analysis to look at the data. When we analysed the data, we found that there was 4 common themes the students used to describe their learning experiences on the programme. So as I'm talking about this, you might want to read the quote on the screen because I won't read out the quote. So the first thing the students said is they spoke about relational learning. So they said there was real benefits of real life learning and learning with the family and understanding, life for the family. They said going out, visiting outside the classroom, in the community, seeing people in their own home, it made dementia more visible. They said relationships with the families were really open, honest and trusting, and this made them feel kind of a bit more confident and a bit more able to explore topics on a deeper level. Next, they spoke about gaining greater insight and understanding of dementia. So students said they had better understanding of the lived experiences of dementia. They had a better understanding of what it felt like to live with dementia over time. And they also spoke about gaining better insight into the role of the carer. And again, some of the challenges that a carer may experience, how carers could live well in the community and that kind of thing. And they said that this wasn't something that they necessarily could gain in a hospital environment, for instance. It was that longitudinal relationship. Then they spoke about how the programme helped to challenge some of their stigma and misconceptions. So as I mentioned earlier, a little over half of the students who took part in this research had no experience of dementia at the beginning, before they started their visits. And the students in this research here said that basically the programme helped them to challenge some of the original perceptions that they had about dementia. They were able to challenge some of the negative stereotypes that they held, and kind of, I suppose, gain a much better understanding of what it was like to live with dementia and get rid of those misconceptions that they had. They realised that people with dementia could still live well with the right support in the community, and life didn't stop, that there was still joy in life. People still got on. They were still people, you know, they could see beyond the diagnosis. And then they spoke about how the programme helped to enhance their dementia practice. So they said, again, that the programme helped to improve their communication skills. They had a better understanding of person-centred care principles. And they spoke about the importance of using kind of tools and things like that in practice to really understand the person with dementia. So they said, you know, dementia passports or life storybooks, rather than them gathering dust in a cupboard, actually take them out and read them and use them in practice. They also spoke here as well about the importance of involving carers in the healthcare environment. Next, the final study I'm going to talk about very quickly is understanding the family experiences of time for dementia. So without families, we have no time for dementia. They are the teachers in this. They are so important. So it was really important that we understood their stories and their experiences and why they wanted to take part. So again, we completed a series of interviews with 18 different people with dementia and their carers. We used thematic analysis, and again, we had 4 common themes that families used to describe their experiences of taking part in the programme. So first, they spoke about their motivation to take part. So for lots and lots of the families, they spoke about, you know, that there was an altruistic reason that they wanted to take part. They wanted to give something back. And for lots of families, this was due to their own experiences in healthcare. And unfortunately, those were negative experiences predominantly that they spoke about rather than positive ones. And they wanted to use their experience to help improve the next generation of healthcare students and the next generation of people that are coming along behind them, that they would have better experiences than they experienced. For some of the families, they said that the programme was recommended to them by others. And for other families, they said, why not? It'll do no harm. It'll be something fun. We'll give it a try. So that's why some of them took part. Next, they spoke about the value to them taking part in the programme. So families felt that they were able to make a difference. They felt that their input, no matter what, students would learn from them and they would make a difference to education and dementia education going forward. Lots of families spoke about the social aspect. They really enjoyed that element of the programme. They really looked forward to kind of younger people coming to their house, you know, talking about different topics and that sort of thing. So it wasn't all about dementia. There was a big social aspect there that they spoke about. And again, this was also reflected by students who quite enjoyed that element of the programme as well. Lots of tea and cake coded in these interviews. And for the carers, they spoke about it was really cathartic for them to be able to talk to somebody who's really interested in them, in their role, in their journey, and just spend time kind of understanding that. That was a kind of a cathartic thing and valuable to them taking part. And then they spoke about student learning. So they said there was a belief in the value of the experience. No matter what, as I said a minute ago, students would learn something. There was an assumption that students learned. And families also spoke about feedback about learning. So it was really important to them that students actually could feedback a little bit about what they got from coming out to see them. Because again, you know, these are very sociable visits. So for some families, they didn't always know what the students learned. So it was really valuable when students fed that back to them. For other families, it said some students didn't feed back this information and they would have liked to have heard that feedback. So that's something we've taken forward when we're preparing students going forward. We try and remind them to please feed back, you know, your learning experiences to the family. They value that. And then they spoke about student factors. So they spoke about the group, so the group dynamics. They said that, you know, the students were professional, they got on very well, there was a really positive fit between the groups, students were fun, and they enjoyed, again, that element. And they spoke about the approach to learning. So again, this was around kind of students who came to them that were really keen to learn, had a list of questions or didn't have a list of questions but were prepared. Again, families really enjoyed that, whereas some other families said, you know, for some students, they felt that they were less prepared, that some of them, they got the impression that they just met on the doorstep and kind of came in to see them. So again, this is information that we've taken back and brought it back into those kind of preparation sessions to try and get students ready for going out to see their families, and try and, you know, let them know about the importance of, you know, be prepared when you're going to see families, have some questions, have some conversations, some ideas. You know, families don't have to do the program they're signing up to support you to learn going forward. So those were the family's experiences. And really, just to conclude about this really quick overview in terms of some of the research we've done, you know, the outcomes for students, we've seen really positive quantitative outcomes in terms of knowledge and attitudes. In terms of their qualitative outcomes, again, you know, these were really, really positive. Students did talk about empathy qualitatively, so they spoke about getting a much better understanding of the lived experience, kind of understanding what it's like to live with dementia and that kind of thing. So that was really interesting there. The best aspects of the program for students really was around that relational learning and going out, you know, outside of the classroom, into the community to spend time with family. And for families, again, satisfaction was very high for them, and they felt that they could make a difference, and they enjoyed the social aspect. I'm going to leave you with somebody who talks much better about all this than me, which is one of our students, and I'm going to leave you with her words. So I'm going to pop this video on. Can you hear that?
So I was having a little look around to find this, and it's the book that I took with me to my visits. I just jotted down a couple of things, and it was actually quite nice because I've just found it today. I was having a rummage, and it was nice to have a little flick through of actually. It brought back quite a lot of memories of the family. Yeah, it's lovely to read through it again. It was incredible that they would let us into their home and talk about something that might be quite difficult to talk about with strangers that they've only just met. And it was a great experience. I enjoyed it a lot. The lady I was with at the family, she quite liked poetry, and she wrote a poem about kind of her experience of, I guess, becoming a carer, if you want to use that word. And I wrote the first line of it because it stuck with me. Today I lost a part of you that was here yesterday. And that was the first visit. I forgot that was at the first visit, and I think that kind of shows you how they let us in. And that poem obviously was very personal. So I forgot that was at the first visit, actually. What struck me was he wasn't angry at all with the diagnosis. I mean, he said he had been in the past, and sometimes it had been quite tough on him and his partner. But he said that over the years they slowly kind of adapted, and it was just, he said it doesn't define me. I remember that, it doesn't define me. It's just something I have. I'm still me, kind of thing. And that was a nice moment, actually. I always remember leaving visits feeling just happier. It was just a nice environment. And again, it was, even though I suppose the reason of this is a learning opportunity as well, but it was also kind of good for the soul in a way. I will always remember them. I will always remember our family that we visited, because they were great human beings. They were lovely. Yeah.
That's one of our past students, Miriam, who reflected on her experiences during Time for Dementia. Miriam has now qualified into practice, and we have some videos of her reflecting back, which is amazing. But that's us. That's Time for Dementia. Thank you so much for listening to us.
Thank you both so much. That was really, really interesting. So yeah, thank you to Yvonne. Thank you, Wendy. We have a question in the chat already. We hopefully will have more time for questions at the end, but perhaps we could touch on this one now before moving on to the final presentation at 3 o'clock. Just to say, yeah, that was really, really wonderful and really enjoyable and very moving as well. So the question we have in the chat is, well, there's a number of questions kind of as one, so we'll have to take them piece by piece. There's, please explain what a hospital passport is, and please share the inner program details between the family and the students, such as what methods and amount of communication were allowed, and also, was there information sharing or restricted gift or duty task considerations? So perhaps we'll do it piece by piece. So for those people who don't know, could you explain about the hospital passport?
Wendy, will I talk about that? So basically that was, they were talking about essentially this is me documents, or, you know, kind of life story documents, that at the time they may have called it a hospital passport, for example. So that's what that refers to. It refers to kind of generically those documents.
And the next part, thank you for that, is the inner program details between the family and students, like what methods and amount of communication were allowed.
I'm not sure I really understand the question. Sorry.
Is the person who asked the question able to expand on that a little, just to explain a little?
I can give a little bit of context if that's useful. So basically, sure. When students are paired, they get a little blurb of information about the family, so a little small snippet of information. But actually then when they go and visit the family, they then explore kind of all areas of the family life. So could families call at any time or text whenever they want to know? It's very much a professional visit. So students will organise, so they do one visit per term. And they'll organise that visit with the family. The families are made aware of, you know, that a visit will happen this term, but they don't share. Students don't share personal information with families. Again, Alzheimer's Society support the families, so if the families need to contact anybody, they can contact Alzheimer's Society at any stage.
Thank you very much. I think that covers that really well. Thank you, Yvonne. So hopefully we'll have, as I said, time for other questions at the end. But perhaps in the interests of making sure that we keep to the schedule, we move on to the final presentation, which is by Dr. Grace Pearson from the University of Bristol. Now, Grace was joining us just before her presentation, so I just want to double check that she's here. Grace, are you here?
Yeah, I'm here.
Great.
Can you hear me?
Okay, good. Yeah, we can hear you fine. So I'll pass over to you now to explain your presentation on transforming training in geriatrics at Bristol Medical School. Thanks, Grace. Do you want to start sharing your slides? Yeah, we
can you see those? And you can hear me? So yeah, I just want to make apologies in advance. I'm currently at a conference and training event in London, and I have managed to find a room in this venue that's empty. It might not be empty for the whole time, so if I have to move halfway through or something, I apologise in advance. Hopefully that won't happen. So yeah, thank you so much for inviting me here today. My name is Grace. I work 50% of my time as a geriatrician at the Royal United Hospital in Bath, and I work 50% of my time as a clinical lecturer in ageing education at the University of Bristol, and that's split between direct hands-on teaching and leadership and education research. So yeah, I'm going to talk a bit about what I mostly did in my PhD fellowship, which was now a couple of years ago, but also moving on to some of the things we've done since then as well. But first, I'm going to take a step back and tell you a story. So let me tell you a story from my own family's lived experience. This is my granny, Mary. She was born in 1925 in Barry, South Wales, which some of you may be familiar with because of Gavin and Stacey. She married young, she had 4 children, and she travelled the world with my granddad for his work. She lived through World War II, the rise of the internet, globalisation. I could go on. And she lived well into her 90s, based out of her large family home in North London, where she lived alone for the majority of the later years of her life. And that's perhaps a familiar story for many of you. Health-wise, Granny had a few ailments and lots of medications, which she never enjoyed taking. In fact, she never liked doing anything that people asked her to do. She was what we would call medically fiercely independent. Her mobility started to decline, however, in her late 80s until she became housebound. And one day she suffered a fall, and there was no one there to help her. And when she lay on the floor calling for help for hours, and so when we did get to her, she ended up going to hospital. And she went into hospital for weeks. Weeks? You might ask why. Well, you see, my 94-year-old granny might have seemed quite straightforward on paper, but her healthcare needs were incredibly complex. And such complexity requires an equally nuanced approach to caring for older people. And that's primarily why geriatric medicine exists. It provides multidisciplinary healthcare for the whole person, tailored to that individual's preferences and their needs. But what if I was to tell you that medicine and healthcare aren't set up to care for older people properly? So geriatricians are there plugging away, but in the UK, there's only 1 geriatrician per 8,000 people aged over 65. But medicine is typically siloed into these system or disease-based specialties, your cardiologists, your gastroenterologists. And I'm not saying that there's anything wrong with that for young people with single system problems, but it's not equipped to care comprehensively for older people. And yet these are exactly the type of people that we need to be able to care for. There are over 11 million people aged over 65 in the UK who account for 40% of hospital admissions, and they occupy over 2/3 of inpatient hospital beds. And that mismatch between population demand and healthcare provision can't be met by geriatricians alone. It's everyone's business to improve and develop our healthcare systems and workforces to deal appropriately with the multi-system, biological, psychological, social complexities of the aging population. So my bottom line is that medical training has to adapt and do so quickly, pivoting so that we're proportionately reflecting population demographics that our graduates will care for, and that's a lot of older people. So I'm not in the business of making everyone a geriatrician, but I am in the business of making sure the entire workforce is grounded in the principles of good, comprehensive geriatric care. They have a good general understanding of things like multi-complexity, polypharmacy, frailty, that they can then use to apply to their older patients that they encounter in their own specialty area, whatever specialty they end up choosing to go into. So it's been my kind of life's work to champion geriatric medicine as a great vehicle for education and training to impart these, what I will now term generalist skills, because if you can get it right for older people, the likelihood is you're going to get it right for everyone. And all of that grounding, as I've sort of started to allude to, begins at the undergraduate level at medical school. Well, so you would think. Medical degrees are jam-packed full of teaching in every specialty, right? Well, unfortunately, that's not the case. So at last estimate, 27% of the world's medical schools were not delivering any teaching on geriatric medicine. That's slightly better here in the UK, at 15% at last estimate, not teaching any geriatrics. But where it is taught, it's only done so for about 4 weeks out of a 4 to 6 year degree programme. And the barriers are the same as they exist in healthcare. Medical education and training is set up in those similarly siloed and compartmentalised ways, and geriatrics frequently isn't represented. And we know, therefore, that as a consequence, medical students struggle to conceptualise the complex aspects of older people's care. And upon graduation, we know that resident doctors feel unprepared for clinical work caring for older people with multiple long-term conditions and frailty. So in a survey of FY1, so that's immediately post-graduation, doctors, a survey just last year found that 60% of people who were entering the workforce as qualified doctors felt that they were unprepared to care for older people. So that's 60% of doctors feeling unprepared to care for 60% of the hospital bed base. It's quite stark, isn't it, really? So what's the solution? Well, those of you who know me in the room will know that I'm going to say it's all about education. We need to equip health professionals with the knowledge and skills to care for people living with complexity and frailty. And it's not just about knowledge and skills, because the evidence tells us that students who have received high quality undergraduate education in geriatrics have better attitudes towards older people as well, and they're more likely to consider a career working with older people or working in the care of older people. So perhaps geriatric medicine isn't just a way of improving knowledge and skill, it's also key to tackling things like systemically ingrained ageism. It's also possibly key to tackling our workforce shortages. So what have we been doing about this at Bristol? Well, complex medicine in older people, or CMOP as I'll refer to it from now on, is an 18-week clerkship, and by clerkship I mean clinical attachment or clinical placement, for medical students in their 4th year of study at the University of Bristol. So that's 4th year of a 5-year degree, generally 6 years if someone chooses to do an intercalated degree. We have the way that medicine is taught at Bristol in those later clinical years is that we have a central university team, and we write the curriculum and the resources that are used, but the bulk of the actual teaching that happens and the execution of that curriculum happens in what we call our clinical academies. So they're the hospitals that are dotted around the southwest, as far north as Gloucester, as far south as Yeovil, as far west as Western, then we go all the way east to Swindon. So yeah, that. So I'll tell you a bit more about CMOP and how it works. So as I said, first and foremost, CMOP is a clinical clerkship, and that's with clinical time shared between hospitals and community settings. We use those settings to integrate geriatric medicine primarily with general practice, with oncology, haematology, palliative care, but with an overarching theme of wanting them to get to grips with general medicine. So medicine at the front door and acute medicine, but in the context of understanding that in the context of older people's healthcare. But as I've alluded to, we predominantly focus on geriatrics as a means for teaching generalist transferable skills. And those generalist transferable skills I've represented here in the blue bubbles around the outside. And the taught elements of CMOP, which are the smaller orange circles around the middle, they're only there to enhance the clinical practice. So they're by no means meant to be the be-all and end-all of geriatric medicine. They're only there to enhance the clinical clerkship. And those taught components are 17 cases for case-based learning. Happy to explain what case-based learning is if you want me to. There are 7 smaller group tutorials, 4 expert lectures, 3 journal clubs, and a book club. And we've recently started introducing these public outreach or community engagement events. So I'm going to explain all of those aspects in more detail. We also assess in the clinical environment. So we use a portfolio of activities that reflect postgraduate workload, things like discharge summaries, doing a ward round, things like that. And we use methods that reflect postgraduate training as well. So workplace-based assessments, some of you might have heard of case-based discussions, things like that. Again, that's all embedded in that generalist transferable ethos of preparing them for their professional practice in the care of older people. So we know from the existing literature that students really struggle to conceptualize and engage with complex concepts in geriatric medicine, such as frailty, for example, through didactic methods alone. Therefore, by using clinically framed teaching in what I've highlighted here, case-based learning, we're ensuring that what we need them to know, what I call the content or the syllabus, is delivered in a way that supplements their predominantly experiential learning of the content. And those topics for the cases were drawn from the British Geriatric Society's recommended undergraduate curriculum, which is freely available online. I've put a QR code at the end. And the cases incorporate the primary literature, also encouraging reflection, hence why they touch on those two broader themes at the side. And where the literature in the cases and in the journal clubs has been done by academic geriatricians within our own networks, that paper's been accompanied with a short Meet the Author video, where I interview that academic to distill the main methods and results of the paper, to ask them why it's an area of interest for them. And our aim with those videos is to connect the students into the academic sphere, because we know that research visibility and research activity is actually a really important factor that attracts people to a specialty. And then finally, I'm not going to touch on it too much, but the expert lectures are the only taught elements that are actually delivered centrally on campus at the university. So like I said, most things take place in our academies. The one exception to the rule is the lectures, and that just promotes interactivity and developing a community with our students. Yeah. So the small group tutorials are really my baby within the curriculum, and they're designed to reflect different journeys for patients, different journeys for doctors through healthcare, through aging, through a professional career. So we use lots and lots of different ways. We look at the journey for a patient through hospital, beginning with a tutorial on how to clerk an older person. We use demonstration and observation to teach about integrating all of those different systems examinations that people are taught into a single examination, and then the special considerations for the care of older people. Then they move on to a ward round simulation, where we use authentic resources from that hospital and real world time constraints, and have students conduct a mock ward round. And that's usually in pairs, although it can just be them on their own. And they're supported in this with a checklist for a model ward round. So we're not just kind of landing them in it and expecting them to know how to do it. That's the checklist on the right-hand side. And that's published in Future Healthcare Journal. So that checklist, I don't know if any of you will be ward rounding, but if you want to know how a ward round works, that's there in the public domain. That's followed by a session using aging suits that simulate the pathophysiology of an aged body. And we don't actually use these very fancy aging suits that are depicted here on the screen. We use very simple things that I have accumulated off Amazon. Things like goggles to simulate visual impairment, earmuffs to simulate hearing impairment, gardening gloves and joint weights to simulate osteoarthritis. And then we get students to do everyday simple tasks, like walking up the stairs, opening medication bottles and packets, trying to read a newspaper, trying to listen to the radio, or trying to have a conversation. And hopefully you can all appreciate that we're building empathy by directly putting the students in the patient's shoes there. And then they have a communication skills tutorial where they role play common difficult conversations that students often have anxiety about having, such as treatment escalation decisions or resuscitation decisions, about breaking bad news, and issues around an older person's mental capacity to make decisions for themselves, and perhaps instances where we as clinicians and the multidisciplinary team with relatives have to make a best interest decision. So all of those kind of anxiety provoking scenarios there. they have an interactive session about what happens when someone dies in hospital, because it really was quite astounding to me that we're taught at medical school how to save lives, and we are taught some palliative medicine, but we're not actually taught what happens when someone dies. And it's a critical part of our role as a doctor is to perform the examination to confirm death and then to write death certificates. And no one is taught that, or at least they weren't until we did a tutorial on it. So they learn about the examination, and they learn how to complete a death certificate by doing practice mock death certificates. And then they finish with more things focused on more career-based things. So tutorials about professionalism, what happens when someone makes a complaint. And then they have an immersive mock fitness to practice tribunal where they take on the roles of prosecution, defence, judge and jury, and they debate fictional medical student professionalism cases. And that's my students there in the top left-hand corner. We provide them with wigs and costumes. I think that's mostly for my enjoyment rather than theirs, but they do it. Maybe it's just for me. So finally, we've used creative methods to promote students to reflect and hopefully to think differently about aging and dying. And that's generally been through connection with lived experiences in storytelling. And that's why I started my talk with the story of my granny. So students and staff come together for a book club where we have a suggested reading list that they can choose from, fiction, non-fiction. And those are books that we've chosen related to aging or dying, that we think portray old age or dying in a way that's different to perhaps the traditional media portrayal. And like with Journal Club and like with the cases where we've been able to, we've accompanied those with a Meet the Author interview. So that's a picture of me interviewing Catherine Mannix, but I also interviewed Wendy Mitchell and also interviewed Lucy Pollock, for example. And we've started with these public outreach or community engagement events, and those bring together interprofessional students and clinicians with members of the public, their caregivers, and importantly with other third sector stakeholders, so charity representatives, care home representatives, and then national funding bodies as well. And in those workshops, we use a creative focus to stimulate discussion about the lived experiences of aging, but also of aging education, so that those discussion groups can come together and self-identify the mismatch and therefore come up with practical grounded solutions of how we can potentially deal with that. So what we've done, we've done one film screening, and we've also had a book event with Lucy Pollock, who's the author of the book about getting older. If you haven't read it, I thoroughly recommend it. What particularly sets us apart? Well, I mean, from my introduction, you might have deduced that primarily we're unique for our duration, 18 weeks. At other medical schools, the average in the UK is 4 weeks. We're also unique for some of our approaches, which I've outlined. But we also integrated a programmatic evaluative programme of research, which has proven its efficacy as an educational intervention. So our successes include a 97% pass rate in medical finals, or also known as the medical licensing assessment. And that's set nationally by the General Medical Council. So we're not just examining our students on what we've taught them, it's the GMC that sets that for us. But also, as I've alluded to, we did this programmatic research evaluation that allows us to compare outcomes between the old curriculum, which was 4 weeks, and the new curriculum, which was 18 weeks. And that was my PhD. So I found that CMOP measurably improved students' attitudes towards older people, and we used a validated scale for that. And that's not just a measurable gain between old and new, but it also tracks across the 18 weeks of CMOP. So you can really triangulate that positive attitude formation down to something we're doing in CMOP. I also collected a lot of qualitative data to supplement and confirm a lot of what I found quantitatively. Wasn't surprised to find that the key facilitators were positive experiences in the clinical environment and exposure at medical school. and role modelling. All of those three things were key to students even being aware that a specialty might be a possibility for them. So it just supports the case for better representation of geriatrics and geriatricians in medical curricula and in medical faculties. It also, the qualitative work shed a lot of light on where we need to go next. So what are the barriers for our students engaging with older people and with geriatric medicine? And they include themes like moral injury or moral distress. They're witnessing ageism in the clinical environment and at the university. And most concerningly, they're experiencing discrimination from older people in the clinical environment. And where that intersects with dementia and delirium makes it really quite difficult to handle. Again, it's an important area that we need to look at in the future. So I'm going to skip over this slide because it's about the challenges and how we overcome them. But perhaps in the interest of time, I anticipate there might be some questions about that, so I can come back to that. So I want to finish by summarising with my conceptualised model for best practice in geriatric medicine education. And I put best practice in quotes because we're not allowed to use that term anymore, apparently. So areas that I think that we're doing well in Bristol, we're offering a diverse clerkship in geriatric medicine. And by diverse, I mean that split of time between hospital and community settings. And critically, that's of sufficient duration that allows students to get to grips with complexity, with frailty, and also it gives them the time to connect with inspiring role models. We're using evidence-based and constructively aligned teaching and assessment methods. We've incorporated some reflective spaces, although I think there's more we can do. We've used authentic competency-based assessment, and we involve patients as equal partners in various aspects of our teaching, although again, there's always more we can do in that space. So now that we've mostly got the bones right, there's a lot more that we need to do with the more logistically, financially, and politically difficult things to do. Stuff like weaving ageing throughout the curriculum from the early years onwards, implementing interprofessional education, and there are a whole host of barriers and logistical and financial difficulties there. And also getting students out of, we are getting students out into community-based healthcare, so primary care, community hospitals. What we're not great at doing is actually truly getting students out into the community. So learning in places where there are healthy, community-dwelling older people, where they are learning directly from older people. So places like care homes, retirement communities, things like that is my longer term goal. So I hope that I've convinced you that if we invest in undergraduate geriatric medicine education, we're ensuring a bright future for healthcare, for our families, and indeed for ourselves as we all grow older. So thank you very much for listening. I'm very, very happy to take questions. Those are my contact details. If anyone is interested in talking in greater detail about this, I can talk about it for a long, long time, as you can probably imagine. And I'd love to hear from any of you. Particularly if any of you are interested in joining our future community engagement events, please do just drop me an email to say I'd be interested in joining in the future, and then I can add you to our list of potential participants. And that QR code, as I said earlier, takes you to a page of various research articles that are relevant to what I've been talking about.
Oh, you've just...
Oh, I'm just muted, yeah. Thank you so much for a great presentation. That was fascinating. Before we go on to kind of general questions for all three presenters, does anyone have a specific question for Grace? Oh yeah, Judith, have your hand up?
Judith, you're on mute.
Judith, you could type it in the chat. If you click on chat up on the kind of band up the top, you could type it in there. And in the meantime, Patricia, you had your hand up for a question.
Ooh, Patricia, if you're on talking, you're on mute as well.
Okay.
There we go.
Just as a throwaway remark, the last speaker mentioned talking about dementia and delirium.
Yeah.
Do they overlap at all?
They overlap.
You know, they're not the same thing, but I just wondered where the overlap came in.
They overlap in so much as they're both disorders of the brain, of cognition, but that's pretty much where it ends. Obviously, dementia is a chronic progressive loss of cognitive capacity. Delirium is an acute confusional state that's caused by something organic underlying elsewhere in the body. The overlap also arises where, in so much as people who have dementia have more vulnerable brains, and therefore they are at higher risk of developing a delirium if they become acutely unwell.
Thank you.
I think I'm not muted now, so
yes, you're all good. Judith, I can hear you.
So I wanted to say to Grace that at the beginning, when I noticed that the patient had two people leaning right over her and she was sat down looking confused, I thought, oh no. But then as I've gone through it, I've been, well, all sorts of emotions. Really upset at the fact how little training doctors get. Delighted that Bristol is showing the way how to do it. I'm very interested in the training and in the results of students. And I'd like to thank you very much because I've really enjoyed all the sessions today. And I think that baby is very, very good. And he's probably going to be a genius because he's been listening to, or she's been listening to it all. But thank you very much.
Thank you, Judith.
My hand now.
Thank you so much. We did have a question from Linda to Rebecca, I believe. It was around if there was a plan to roll out the voice study or tailor it for healthcare assistants working on the wards as well. Bless you. Linda says, I witnessed a great variation in how effectively they interacted with patients living with dementia, and they seem to be the ones that the patients saw most frequently. So I wondered, do you have an answer to that, Rebecca? Is that something you've considered?
Yeah, so sorry, it wasn't clear. So in voice 1, we just went for professional registered staff, but in voice 2, we included healthcare assistants. And we're very glad we did, because in fact, there were a lot of the data from them. And in fact, I think both the clips I showed were of healthcare assistants. So we've got lots of beautiful practice from the healthcare assistants, which is really lovely to be able to model that to healthcare assistants. And we included several healthcare assistants in our expert stakeholder groups for developing the training to make sure that they felt it was appropriate and met their needs. And I think that really helped and supported the training and made it accessible to them as well. So yes, it is. The voice 2 stuff is already accessible for them, hopefully. And yeah, so thank you for highlighting it.
I think we have time for one more question before we finish at 3:30. Does anyone have any last point they want to raise for any of the 3 speakers? Not you. If not, I had a quick one for Rebecca and Alison, which was around any reflections you had on kind of knowing what this might be tricky now, knowing what was important to include in the training, but how you actually implement that in practice. So we've had a really good session so far, but she's beginning to lose it. So yeah, Rebecca.
Oh gosh. Oh, now I've got distracted by the so how did we identify them? What we trained?
I suppose what I was thinking of is the difficulty of what is important to include in the training, but actually how to include that, how to implement it so that it makes a difference in practice. Did you mentioned that you had a kind of intervention team?
So do you mean the people that we developed it with? So I guess the people, so we included, so the study team ourselves include quite a number of clinicians who are currently working in practice, so that's really helpful, and specialists in education and medical education and healthcare education. And then we included extra stakeholders from clinicians from the wards,